Hi, everyone, and welcome to the Rehabilitation and Physical Medicine Special Interest Group of SIAP for our education session today. My name is Lynn Tanner, and I'm one of the co-chairs, education co-chairs, I guess, along with Ann Gonzalez, and we're excited to present to you today the safety of pediatric rehabilitation. We have two speakers, Dr. Laura Gilchrist and Dr. Ratna Soebadi, and I'll have them introduce themselves, give it a little background when they present. But first, we just a little bit of business. For SIAP, just a reminder that to renew your SIAP membership for this year. So there is a promo code, a 5% discount. So just a reminder on that one. And then we have, the annual Congress coming up in Amsterdam this year. And so please submit abstracts. They're due April 1st. So about a month away now, and there are no extensions. So you have to meet that deadline. And they're welcome from everyone, of course. And so we hope to see you in Amsterdam. And with that, I'm going to stop sharing, and Dr. Soebadi will share and go ahead.
Yes, hi. Hi, hello everyone.
Hello.
I'm Ratna and I am so happy to see you all again. And thank you, Lynn, for inviting me to participate, and I hope I can contribute something. Okay, let me start sharing my PowerPoint. Okay. Wait. Okay. Well, I'm Ratna, as you can see, Ratna Soebadi, and I am from Indonesia. This background is the Komodo Islands, where they have the ancient dragons still living there. But I'm working in Surabaya Academic General Hospital of the Erlangga University at the Department of Physical Medicine and Rehabilitation. I'm a physiatrist, and aside from being a pediatric consultant in rehabilitation medicine, I've done my diploma in palliative medicine. Okay, and now I thank you very much for attending, and I'll try to share my slides now. It's safety of rehabilitation and physical activity during treatment for childhood cancer. Pediatric cancer is something that do need rehabilitation. And the rehabilitation is at all stages of the disease. Even before we have the diagnosis of cancer, when a child presents to our clinic with pain or with a deformity, at that point, we actually already can provide some relief. Some relief and some PMR interventions to maintain comfort, functional ability, and stay physically active. These disabilities can be cancer-related, treatment-related, comorbidity-related, or growth and developmental issues. Comorbidities such as the child is diabetic or the child growth and development issues like Down syndrome. And this all significantly impact on the growth and development in the future because of lost opportunity to gather the experiences necessary to develop physical and psychosocial life skills. But having cancer and its consequences means that there are challenges in rehabilitation, but also that these all are potential triggers for patient safety issues. Well, it's pain, of course, and then we have the cancer related at all systems of the body that can be influenced by having cancer, or the impact on the patient of having cancer, debility, metastatic disease, chemo, radiation, surgery, and pain. And by that, then the child will be impaired and have functioning and problems due to fatigue, pain, weakness, loss of mobility, lack of acquisition of life skills, risk of falling, depression, and social isolation. These all are consequences of cancer, but also risks for patient safety. And the PMR team multimodality approach is actually, PMR is a transversal specialty. It's not directed to a disease, but it's directed to the disability, the consequence of having a disease. And our core business of all professionals in PMR is reducing these disabilities, the impact of the disabilities for activity and optimization of participation. And for that, we all are patient-centered and having a holistic approach. It's not about the organ, but it's about the person, how the person is able to live. And for that, we need to involve each other. And we also sometimes need to involve other health professionals. And we operate in a collaborative, multi-professional team, sometimes led by the physiatrist, but sometimes by anyone else who is the more appropriate, which includes also that we have to listen to the patient and the caregivers and take them into account. And we can provide a broad range of therapies by many different healthcare professionals, multimodally together, not sequential, but we can do it multimodal at certain points. But it all should be individualized to the specific patient. This interprofessional collaboration is where we, the team, should agree on the goals and set realistic goals and agree on who does what to reach this particular goal. So we have a shared strategy, and we work together at our different fields. And this often is best done sometimes in joint sessions, where the physiotherapist may work on the joints and the lower extremity, and the OT can play with the kid to improve attention or cognition. And this may avoid overstimulation, fatigue, and or repetition of therapy. And these shared strategies will improve functional outcomes and sometimes even better survival. Now, this PMR way is actually unique, not only because we are not disease-oriented, but also because in different settings, we have different risks and different challenges. In an inpatient ward, somebody else's work. If we work as a PMR team on consultancy basis, in that PMR world, we are still somebody else. We're not at home. And they are very busy. They have their own issues with this person. And then we come and we want this and we want that. We want to do this. And we may come at the wrong time. It needs a lot of coordination. And if we are not well informed, we may trigger some patient safety issues. This is in the inpatient ward. And then we have the PMR ward where this is our home. We work together if we have that. And we have the physiatrist, we have the PT, OT, and the speech therapist there. And we can set the time, we can use our protocols, and then usually it goes well. The outpatient setting of a PMR department often is hectic, and you have multiple professionals there. Teams may be incomplete, not working at the same time. A teamwork does not seem to exist sometimes. And therefore, the reality of a PMR outpatient setting is specific for a huge number of patients, rapid turnover, short time of evaluation, short time of treatment, limited sessions, rapid answers to treatments, while the cancer patient may be rapidly changing. So the last week, the child came in laughing and active, and then the child comes in again for therapy, and the child has a swollen arm. She has broken her humerus. And for that, we need to anticipate, and we need to be prepared to prepare protocols, algorithm, guidelines, or simple prescriptions to overcome the difficulties of the incompleteness of ability to be present. And for that also, standardized electronic medical records are very, very important. How to comply and still do interprofessional collaborations in this busy setting. The physiatrist is liable often for the situation. But in these difficult situations, management should be already be based on protocols, on previous decisions as what to do, when. And in case these protocols cannot be applied for some exceptions, then we should communicate. And nowadays that is not hard because we can do WhatsApp conferences, we can do team conferences online. So that's not that hard. But we should be willing to do that. And then still we do need to have some team meetings and discussion, although maybe in a modified way. And we should understand the roles of each member of this team. We should utilize the professional skills of every member. We should understand roles and know when to refer and when to include this particular profession. And we do need to communicate with each other clearly and nicely and build a foundation for better collaboration. And this idea of learning to work together is actually best if you start it in the training of the physiotherapists, training of the doctors, and have already team discussions at the training level. And last of all, artificial intelligence, nowadays AI, can help us to communicate and coordinate. We can use chatbots, virtual assistants, apps for medical professionals, language translation. And if we use our medical records properly, then we might be able to do risk assessments and to do resource allocation and identify the high-risk patients so we can reduce also the accidents with the patient. And awareness, there is a core set of childhood cancer outcome. And these are the issues there. This is the journal is here. All these issues, we do need that into account because that are the sources.
Sekarang lihat WA ada.
And these interventions are also poses also risk for the patient. And my last slide is that for patient safety, we need to collaborate, gather information, use objective measurements, assessment tools and outcome measurements tools, use standardized protocols, electronic medical records, collect data, and analyze and improve patient safety by using the data. And this is the sum of my bibliography. And thank you for your attention. And I hope I have brought some issues to think about. Thank you. Thank you.
Yes, thank you so much, Dr. Soebadi, because I think that's a really wonderful spot for me to jump off from. So I'm going to go ahead and share my slides as well. So again, I'm Laura Gilchrist. Let me share my slides here. Hopefully you can see it, or Lynn will tell me if she can't see my slides. And I'm going to talk a little bit about that data that Dr. Soebadi was talking about what might we do in order to collect some data and analyze the data to better understand what is the safety of providing rehabilitation interventions while children are going through their cancer treatment. And so that is exactly something that we did at Children's Minnesota. And it's a collaboration between Children's Minnesota and St. Catherine University, where I am a professor of physical therapy. So I didn't actually put my credentials on this slide. So to get to know who I am a little bit more, I am a physical therapist by training, but I'm also a research scientist. And so that is the background that I'm speaking about this from. Of course, as you probably understand by my accent, I am from the United States, and in the United States, I'm located in the very middle north part of the United States in Minnesota. So just to give you a little bit of context about where this information is coming from. And it's going to be a beautiful day and not terribly cold today. So let me see here. I have to get my slide to go next. So we know that when children are going through cancer treatment, as Dr. Soebadi said so well, that we need to be making sure that they're continuing to move, that they're continuing to develop. There's so many reasons for rehabilitation to be a component of that. And if we are going to be participating in that, we also, while they're undergoing their cancer treatments, there are a number of impacts of chemotherapy and radiation that can make it a little bit more difficult, not the same kind of safety parameters that we would typically see. And so for somebody who's in a different pediatric condition. So things such as anemia and thrombocytopenia and neutropenia and the potential for electrolyte abnormalities and cardiotoxicities. There was a time when we didn't have great direction about how we should deal with those blood values or the blood counts. And if we had waited until those lab values are normal again, many children would not be able to exercise during much of their treatment. And so that really brings us to think about the risk versus benefit analysis of what is the risk of doing physical activity and rehabilitation, strengthening, endurance training while children have low blood counts. And then what is the other side of what's the benefit to that? And it's actually a reduction of risk potentially to keep them moving. As Dr. Soebadi said, maybe there's some potential improved survival. Maybe we have fewer issues that can happen if they are able to participate in these kinds of rehabilitation activities. So this is something that we at Children's Minnesota and with my institution, St. Catherine's, we had the really beautiful ability to collect some data on this. At Children's Minnesota, they were functioning as a rehabilitation group using a symptoms-based approach to the provision of exercise and rehabilitation. And we had an opportunity to look at our data and say, what is the safety of this approach? Because we were practicing in this approach, what is the safety? And we published this in Rehabilitation Oncology in 2017. And I'm happy to share that reference if we need that. So let's talk a little bit more about what is a symptoms-based approach. It is not using, and the American Physical Therapy Association had previous guidelines about when exercise should occur based on lab values, including if somebody had a hemoglobin below 8. Initially, it was no exercise whatsoever. And then they updated their guidelines and said, if their hemoglobin's below 8, maybe essential daily activities. And likewise, they also had some original guidelines about what should a platelet count be for different kinds of exercise. And you can see that they would say that resistive exercise shouldn't happen unless they had, initially it was greater than 10 for their hemoglobin and greater than 50,000 for their platelet counts. And that was back kind of in the day. It was updated in 2017. And then it is now, they are suggesting more of a symptomatic approach, a more nuanced approach, because we know that somebody whose blood counts have dropped precipitously, that is a different patient than somebody who has chronic low counts and have had the ability to adapt to those low counts. So now APTA is suggesting a more symptom-based approach, which is exactly how our clinicians were practicing. So when I say a symptoms-based approach, and that could be different between institutions, how you practice it, it might be different than how we practiced it, the age of the patient, the disease status, the treatment timings, those kinds of things. But we came up with our understanding of what the symptoms-based approach was at Children's Minnesota. And it included things that we had to treat all patients as if they had a depressed immune system and make sure that we had a clean environment and equipment. Then therapists were free to, they didn't have to go and find the lab values before they could do exercise. That was not going to be feasible. It was not going to be able to get people to be as active as we wanted them to. So we use symptoms to modify when they would do activities, including did they have excessive fatigue, headache, or pallor that indicated anemia? Or did they have bruising that was noticeable or reports of abnormal bleeding? Was there the presence of a fever? What were their resting vital signs? And then other symptoms. Are they nauseous? Whatever else is going on. And so then therapists had the freedom to modify and then, of course, modify on the fly if their patient wasn't responding well to the treatment. So that's how they were practicing. And so we decided to study what was the risk in patients. And of course, everybody was receiving the intervention. So we couldn't really take a look at if we did or didn't give the intervention. Instead, we looked at if somebody had very low counts, what was the safety of using this approach? So we did a chart review study of our pediatric population aged 3 to 18 years. There were 147 patients of many different types. Just for you to know, the vast majority of them were in the outpatient setting at that time. And because acute lymphoblastic leukemia was the most common diagnosis, in the US and in Minnesota, the vast majority of that treatment is given in the outpatient setting, and we're lucky enough to be integrated into that oncology clinic as therapists. So we took a number of different sessions in rehabilitation. They had to be within, not in the first part of their treatment, but still within treatment. And then we recorded what happened in PT sessions or OT sessions, and then looked for critical or adverse events that occurred either during the session or up to 2 days afterwards, because we knew it might take a little bit of time to get documentation. We also looked at what their lab values were during that. So just to give you an idea, on the left, it just shows you how many people had normal lab values. So it's not how many were abnormal. This is how many were normal. And pretty much very few people had normal lab values. Almost all of our patients were below on their hemoglobin, so they're anemic. More than half had thrombocytopenia, and they have abnormally low white blood cell counts. How often did events occur? In approximately 9.1% of sessions was there an adverse event. But I want you to take a look at what these were. There were no deaths. There were just a few things where there were a number of people who had tachycardia without an intervention. Nobody needed a medical intervention for their tachycardia, so we almost talk about that as an incidental finding of tachycardia. We had one fall, one pain complaint, a few fevers, and some other subjective complaints. So in reality, the number of adverse events were very, very low, and there were no critical events that occurred. So what did the risk look like? And so we can see on the left of the first chart, we see those folks who have no event versus those who had an event. And when we looked at the relative risk of having an event with a low hemoglobin below 8 grams per deciliter, yes, it's more common to have an event if you have a low hemoglobin. But when we omitted the tachycardia, the risk came down to being negligent, or negligible, not negligent, negligible. So really, and we omitted tachycardia because that's a natural response to having a low hemoglobin. White blood cell counts were not associated with adverse events, and low platelet counts, we did see an increase in risk. But one thing I want to point out here is that we had very few patients who had really low platelet counts. And because of that, and really not being able to feel like we could trust this data, I'm going to share some adult data with you for a second as well. Because in a separate article that was published in the Archives of Physical Medicine and Rehabilitation a couple of years ago, we looked at those patients who had stem cell transplants. And of course, these are much sicker patients. They are all hospitalized. They have higher rates of adverse events. We use that same 20 or 48-hour time frame. What I do want you to notice is that nobody died. We did have some bleeds that occurred. And if we're looking across, the red is during rehabilitation. If you see that on the bottom, within 2 hours is very few. We had one bleed that was probably unrelated to the therapy itself, and one cardiac arrhythmia, and more things happened the farther out you went. So the relationship and the association might be a little bit different. Okay, so this is a lot of data, but basically what I want to look at is the bottom here is what is the risk if somebody has extremely low platelets or lower platelets, and this is a bigger population here. There is a slight increased risk. So if you can look at the odds ratio that's on the side, it's about a double risk if they have those low platelets. So just something to keep in mind. But what about critical events? Okay, and critical events occur. And in this population, the critical events, there was one person who had a stroke. And so, which is probably not unheard of, especially in adult patients with really low platelet values. That can certainly happen. There were no deaths as well. And adverse events didn't occur during rehabilitation and typically occurred a couple of days out. So overall, what the findings were was that there are some data to support looking at hemoglobin levels, that what really didn't increase any risk of if somebody was anemic, it didn't increase the risk of events if they were in the outpatient setting. But in the stem cell transplant population, it did increase the risk, but there were very few critical events. And a critical event is something that could be life-changing. And what I didn't give to you today, which isn't published yet, is that there is some data that general mobility and endurance exercise in those folks with very, very low lab values, if they can do it, and it is actually protective for them. So just something to think about and look forward to that data coming out. When there are very low platelets, there is some increase of risk of having an adverse event, but it probably isn't going to occur during the rehabilitation session or shortly after. And so it just may be that these folks are critically ill at that point in time or ill. So, and they may have had those events anyway. Yet, the adverse events that did occur were typically easily managed, and the benefits of rehabilitation may, in fact, outweigh the risks of these adverse events. We just have to know what we're doing and do it safely. So that's where I'm going to end my part, and I'll stop sharing.
Thank you both. That was really great. What we wanted to do, I think what our participants have asked for in the past is some discussion, especially since, I think how we modify sessions and what we do at our own organizations may be different from place to place. So we thought it would be good to have a discussion. So we're going to break up into 2 groups. So it's a little bit smaller for about 15 minutes, and then we can come back together as a final group. So you will be sent to a breakout room here in a moment.
I think it worked.
Let's wait until everybody joins us back. All these boxes moving. Just wanted to give everybody a chance to come back to the main room. I think, you know, to summarize, it sounds that some people are treating symptomatically. Often they have other medical professionals around them to discuss, you know, any concerns with, you know, we can work as a medical team. Others have more of a cutoff around platelets under 20,000, hemoglobin under 8. So I think that there is a variety, but you know, I think there is a general sense that I was sharing with our group that we can think about what's the safety of not doing rehab, what's the safety of people being in bed and not getting up and moving and working on their skills. Is it possible to have an email? So does anybody want any final comments? Dr. Gilchrist, Dr. Soebadi, do you have anything to share after listening to the discussion?
Yeah, thank you. Well, I'm so happy to hear that the multidisciplinary collaboration is actually working and well appreciated and useful. And secondly, that I like very much the statement that what is the benefit of not doing something and staying in bed? Yeah, staying active, you can modify the level of activity, and that needs some wisdom. Thank you.
I think
That's for me.
I think Dr. Soebadi said it very well. What is the risk of not doing anything? And we need to, because from what I'm hearing from Dr. Tanner is that we have a lot of different things going on. There could be the opportunity to collaborate to figure out, okay, what does that look like? And what is the safety across different populations and not just under one approach? So love it.
Well, thanks everybody for joining us today. Just a reminder, right, to put in your abstracts for the conference. They're due April 1st. So everybody needs to put in your abstracts because we all would like to learn from each other at the conference, and plan on registering for the conference in Amsterdam next year. Pia, do you have anything to add? Anything else? Are you Anne as well? Anne Gonzalez is here. She's the fellow education co-chair, and Pia is the co-chair of the group.
Yeah, I would just like to remind everybody that this recording will be available in the SciOp YouTube channel in the following week, just so you know.
All right, everybody, have a nice weekend.